undergraduate teaching head of the Division of Otolaryngology. Did I say that right?
Yes.
I practiced it. Head and neck surgery, Department of Surgery, University of Saskatchewan. And he attended medical school at the University of Saskatchewan. He won the gold medal for top graduating medical students and was awarded top prizes in internal medicine and pediatric awards. He was also very athletic, and in 1987 he was captain of the University of Saskatchewan Husky men's hockey team silver medal national championship. In 2015-16, he was president of the Canadian Society of Otolaryngology, head and neck surgery, 71st annual Canadian Society of Otolaryngology, head and neck surgery. Its scientific meeting held in Saskatoon for the first time in 2017. 2010-15, he was on the executive council secretary of the Canadian Society of Otolaryngology, head and neck surgery. 2002-18, division head, Otolaryngology, head and neck surgery, Department of Surgery, University of Saskatchewan. From 1993 to the current time, he's the teaching head of the Division of Otolaryngology, head and neck surgery, Department of Surgery, College of Medicine, University of Saskatchewan. In 2016, he was awarded the top surgical teaching award for undergraduate clinical care in Department of Surgery, College of Medicine, University of Saskatchewan. 2012 to the present, he's a member of the Canadian Society of Otolaryngology, head and neck surgery, and undergraduate medical education committee working group and task force. The member of the Canadian Association of Head and Neck Surgical Oncology, 1995 to the present day. He's the chair of the Saskatoon Cancer Center Head and Neck Tumor Board Grounds. 2017 to present, he's the co-chair, Royal College International Kuwait Otolaryngology Head and Neck Surgery Fellowship Exams. 2018 member of the advisory board of Humboldt Broncos Memorial Fund, and 2020 board member, University of Saskatchewan Husky Athletics Board of Trustees. So welcome, Dr. Scott.
Thank you very much. That was impressive. Normally when I give that's my short video. They read only part of it. That was impressive. That's impressive. You did great about that. Great. So I'm happy I was asked to speak here today. Because it's the end of the day in a smaller group, I'm going to tailor my presentation. I've lectured so many times that there's no human being that can concentrate at the end of the day after all the information that has the discs that have gotten into your cylinders of information. So I'm going to tailor my talk just a bit. Very happy to be here. I'm Saskatoon born and went away for 5 years to train. Of all the things I've done, I have very active interest in HPV infections, which is why I'm here today. But I work in the Middle East as well. I'm the chairman for the Royal College Fellowship exams there, and I just got back from Kuwait in October. That's my last job, in addition to the non-medical work that I do. I was over here in the last lecture, and I'm very proud to say that I think I'm the longest standing specialist that continues to do itinerant clinics in the north of Saskatchewan. I have gone to Ile Lacrosse and La Loche for over 25 years. Those specialists who do it pack it in after a while. I am still going. I go through Northern Medical Services. So I have a great interest in Indigenous health, and as a parallel to the dental issues that the kids have, they have equally bad ears. So I'm very intrigued by the ear disease up north, and I continue to travel up there again through Northern Medical Services. I also go to Meadow Lake as well, so I go to Ile Lacrosse, Loche, and Meadow, and as I said, I've done that for 25 years. Why am I speaking to a dental type of conference? Is I'm an otolaryngologist head and neck surgeon, and I deal with mouth and throat cancer. And I'm going to give the dental community great credit. The dental community, and I'm not going to cite family doctors, but the dental community is unbelievable at history taking, awareness, education, examination of the oral cavity. Far rivals the family physician, much better than the family physician. So the dental community is the benchmark of oral cavity exams. And then on that end, I've been working with the Alberta Dental Association that are extremely aggressive in being at the forefront of anything related to oral health, including HPV. So again, because it's the end of the day, I'm gonna try and wake you up. Like the food put to this late and maybe with some talk, but I'm gonna try and wake you up, because it's such a long day. So this is gonna be a bit of a shock to all of you, because there's something in our community, in the world actually, that you may have heard snippets of, but not the whole meal deal. So I'm gonna try and spell out the whole meal deal. In my presentations, there's a lot of statistics, but I'm just gonna try and spell out what we're talking about. And it doesn't matter who you are, what you're involved with, what your position is, be you a dentist, a dental hygienist, someone who's involved in oral health from the paramedical personnel, the paramedical personnel. If you're a human being, if you're a mother, a father, or just a human, it's good to know about this topic. So what I'm talking about is HPV stands for human papilloma virus. And I'm not infringing on anyone's intelligence by starting at the beginning, but there's some very confusing things about the education about this disease. So human papilloma virus is a virus. Again, before Corona came out, before COVID came out, we had a lecture that said the cancer epidemic of the century, and I had a lecture that started the vaccine of the century. This is before COVID came out. So you're aware that there's an HPV vaccine, which they now give. It's optional, like all vaccines, but it's given through a school program in grades 6 and 7. So it's actually at a very young age. It became available in Saskatchewan in about, let's say, 2019. When I was the president of the Canadian Society of Otolaryngology Head and Neck Surgery, one of my goals nationally was to get that vaccine out free, meaning the government pays for it, for boys, because there had never been a boys program, there'd always been a girls program. And on that note, HPV is the sole cause of cervical cancer. So it's very bizarre. I'm a cancer surgeon, I'm an ENT doctor, but one of my interests is cancer. So I do the head and neck cancer, big surgeries, little surgery. But HPV is a virus and it causes cancer. So most of our cancer is not caused by viruses, right? I mean, the common ones are breast, lung, prostate, colon, thyroid. Those are not caused by viruses. Only a couple cancers that are caused by viruses. So this is really unusual. I mean, we just had a pandemic with Corona and COVID, and it doesn't cause cancer as far as we know, it doesn't. But it causes a lot of other things that have obviously turned our world upside down. So HPV will recognize it causes cervical cancer. So back when they decided, someone invented a vaccine for HPV, and time has shown that it's actually prevented cervical cancer, and the incidence of cervical cancer in women is down. And so it's astounding that we have a hard time preventing cancer in other parts of our body. I mean, we have some smoking cancer, so if we don't smoke, you won't get it. So we actually have a vaccine that prevents cancer. It's amazing. I mean, it's just, whether you believe in the vaccine or not, the selling of COVID vaccine or the, making it attractive to people is a tricky venture. But can you imagine if you said, here's the vaccine, that you won't get the illness, but you also won't get cancer? It's amazing. So not many people know that the HPV vaccine really prevents cancer, and there's just an indication to prevent head and neck cancer. There's always been an indication to prevent cervical cancer. So I think you understand what's happening. There's HPV, the human papillomavirus, that causes cervical cancer. But here's why I'm here today. There's something new. And I've been in practice for my daughter was born, I've been in practice for 28 years. My daughter's 28. She's 20 now. So when I first started, when I saw throat cancer, when I say throat, I mean like tongue, tonsil, larynx, pharynx, whatever. We only saw that in older men that smoked and drunk too much. And so I used to actually say to my patients, maybe you're worried about cancer, and I'd say, you know, sir, man, if you don't smoke, you probably won't get throat cancer. So that was about 20, 25 years ago. So now that's actually out the window, it's out the window. Now, I think, well, more so now, but about 20 years ago, we started seeing males and females, but mostly males, 41, that would be my age, so late 50s, maybe early 50s, never smoked, white collar for whatever reason, develop throat cancer. When I say throat, it's tonsil and base of tongue. So the HPV induced cancer epidemic, which is out there now, whether you're aware of it or not, it's an epidemic, is in the oropharynx. 2/3 are in the tonsil, y'all know what the tonsils are, and 1/3 are in the base of tongue. So it's not in the oral cavity. We see HPV-induced cancers in the oral cavity, like in the tongue, the floor, mouth, and many were picked up by dental personnel. I mean, half the referrals now for mouth cancer from dentists and dental personnel. But the HPV of significance, because we don't know the significance in the oral cavity, is in the oropharynx. So the reason I was asked to speak about this issue is because there's an epidemic of oropharyngeal tonsil cancer caused by HPV that is the only epidemic of cancer you'll see in your lifetime. Because cancer incidences go up and down a bit in statistics, but the male throat has done that. The cervix has actually gone down. We have some other cancers and by statistics that have gone up a bit, skin and thyroid mainly. Some of the other cancer, the incidence have gone up just because we find them more often now because we have better screening techniques. But throat cancer in males, and it affects males 4 to 5 to 1 more than females for whatever reason. So to wonder how you get this and how do you get HPV? HPV is basically classified as a sexually transmitted disease. And this will shock everyone, but 80% of human beings have been proven to have acquired the disease, whether they know it or not. So we assume, because it's 80%, that basically every human being that is alive and breathing probably has been exposed to HPV. It is a sexually transmitted disease. It can happen from sexual intercourse. It can happen from oral sex. That's a high rate of transmission. It can also happen from whatever you call it, deep kissing or kissing and swapping spit. So basically, you know, I've had people say, you know, who's at risk of this? I always say, just if you're a human being, you're probably at risk of this. So the bottom line is the human race gets exposed to HPV when you are first sexually active, in any means when you're first sexually active. And there's the studies alarm all of us as parents, because, you know, it used to be whatever it was, 17, 18, 19, now it's 12, 13, 14. So I don't study this, but people study this. And that's why they decided that they're going to give the vaccine to grade 6s and 7s, which freaks a lot of parents out. But the other thing too is we do want immunity to be acquired for 2 years, sort of before the sexual active. So when the vaccine's offered in the schools, I mean, you know, it's a voluntary vaccine, like all vaccines, and then you have the right to choose it or not, and parents obviously are telling the kids to grade 6 or 7. But the whole point is to catch kids sort of 2 years before they're on the average sexually active. So that's the Gardasil vaccine that's out there that is again meant to prevent you from acquiring HPV disease. And then here's the confusing part of it. If the human race is sort of getting the HPV infection, you don't even know you have this, an asymptomatic infection. You can do studies where you find the virus in saliva, and that's where the dental personnel come in, because most of the studies all have to do with saliva and oral cavity secretions. But what happens is that you get exposed to the virus, and there's 200 types of HPV, right? There's 200 subtypes of HPV virus. So you acquire the virus, you have subclinical illness, meaning you're not sick. But you carry the virus in your mouth and your throat, whatever, probably for about 2 years and then it goes away. But here's the kicker. And this is so bizarre. Some human beings, and there's a lot of them now, and it's just, some human beings will get a cancer 30 to 40 years later after acquiring the virus. It's a hard thing to understand, but that's what's happening. So if we have someone come in my age or 10 years younger, and they have, and I'll tell you how it presents, but they'll present with tonsil cancer. We do a stain once we get tissue biopsy, and the stain stains for P16, which identifies subtype 16 of HPV. So it's obvious that the virus has caused the cancer, just like in cervix. And there's been a gazillion research studies to prove it's not a mistake, the virus causes the cancer. Now, so in the throat, of course, smoking used to cause it. About 80% of our throat cancers are HPV and 20% are smoking, and it just keeps going up. So the majority of cancers we deal with in the throat are HPV induced. So you may have heard it on the news, but part of the reason we lecture and we educate, we communicate, especially to professionals involved. I mean, if you're involved in oral health, that's where the HPV starts. That's why we educate. It's a hard concept to understand that you get the latent cancers 30 to 40 years later. So most of our cancers typically, here's the other bizarre thing about it, these tonsil cancers are really subtle. Most of our patients come in with a metastasis already, meaning, you know, Mr. Smith is 58 years old and he goes to his doctor because he has a neck mass right here. And then the astute family doctor thinks, oh my gosh, I've heard about this epidemic of throat cancer and maybe that's a metastases. And there's a patient doesn't smoke, doesn't drink. And then you look in his mouth, you might see the tonsil cancer, you might not. Sometimes they're subtle, sometimes they're obvious. So in 1 week, I saw 5 new cancers. There's professionals in town that have this. The treatment, the cure rate's quite high of these HPV-induced throat cancers. The cure rate is almost 80%, but you go to near death and back during the treatment. It's one of the worst. It's chemotherapy and radiotherapy. It's not surgery. We deliver chemotherapy and radiotherapy, and it just brings you down. A lot of patients just want to knock their life in when they're getting their treatment until they recover. The treatment also has significant side effects. There's a lot of side effects with the chemotherapy and the radiotherapy, and some aren't cured. When they're not cured, then they need salvage surgery where you basically have to take half the head and neck off, and it's not pretty, and the cure rates aren't that high. You may have heard of robotic surgery. Sometimes an alternative to chemoradiotherapy for these HPV-induced throat cancers is robotic surgery. One of the problems about the back of the throat is very hard to get there with our human hands. So I was actually, one of my projects lately is I found a donor and helped with the philanthropy of getting a donor to buy the robot. It was actually a patient of mine who had head and neck cancer, not HPV, but had a head and neck cancer, and he was moved by the whole medical community and the service he got that he purchased the robot for Saskatoon, which is amazing because you have to be quite a big city to have a robot. So we have a robot at St. Paul's Hospital that has the ability to do some throat surgeries. It's mainly used for urology and prostate cancer because that's another area where it's hard to fit the human hands into comfortably to do surgery. But so robotic surgery is an alternative for treatment for head and neck tonsil cancer, HPV induced. Having said that, most of our patients get chemoradiotherapy for it. So just again, end of day, I haven't got to my slides yet. Don't worry, I need not even get there. I hope you have an understanding of, I would ask to speak on HPV-induced head and neck cancer. Head and neck's a funny name, but it's mainly tonsil cancer, which metastasizes to the neck. It's a new thing that we've never seen before, and we're seeing it, the incidence I'll give an example. The Cancer Clinic or the Cancer Canada statistics are so slow. The latest data we have for 2016 is pathetic. If you ask them for data, they'll give you 2016. It's just unbelievable. And that's sort of the way the US is somewhat. But our statistics show that up to 2012 or 16, and it's partly extrapolated, there's a 52 incidence increase in cancer. And in the cancer world, we normally see 3 or 4% incidence increase. So it's out there, and it's actually bogging down the healthcare system, that they can barely keep up with the chemotherapy and the radiotherapy for this new cancer. What about all the other cancers, breast cancer, colon cancer, prostate cancer, lung cancer, all the common ones. So as I said, there is a vaccine available. And one of the things about the vaccine, of course, and I don't have anything to do financially with the vaccine. I do believe in it, because if you tell me, doctor, you have a tool to prevent cancer, well, not many tools to prevent cancer. And you can eat well, you can exercise, you can avoid smoking, but for the most part, if you get cancer, it's sort of it's usually a bad luck factor, not something you've done. But certainly, other than prevention, which is almost impossible to do with HPV, the vaccine does prevent the cancer. So what was happening, we were immunizing girls. But then if you understand immunizations work, you can't just immunize half the population. There's herd immunity, which means the population of virus goes down. So it was almost silly for us to immunize females. It would work for cervical cancer, but for throat cancer, you can't just immunize one sex. You have to do both sexes. So that's why we finally convinced the government to supply boys with vaccine free. Now, anyone that knows me who believes in vaccination, if they miss the school program, they all go and get vaccinated. Never if they hear a story about a patient who has this cancer cured or not, because the treatment is so near lethal, they go up and get vaccinated. The vaccinations are indicated for up to age 45, as long as you're at risk of acquiring the disease. Having said that, the older you get, you may not live long enough to have your latent cancer appear. So there is an end to sort of vaccination at age 50 or 60, but it's really open to any age at this point. Maybe just because it's end of day, why don't I just see if there's any questions, and I could, yeah, if you have any questions. Yes.
Well, someone does have that,
Yeah.
as an adult, like
Yeah.
30, do you still recommend getting the vaccine?
Right. So you're talking about an adult who has the cancer?
Yeah.
Yeah. So the assumption is if you have an adult who's like in their 40s or 30s, but I mean, we don't usually see it that now. Maybe, I think the youngest I've seen is like 35, 38, 40. The most common age is sort of 50 to 60 type of thing. But, once someone has this cancer, it's a really tricky business. One, they have cancer. And you have to educate them on that. You have to get them investigated, treated. They see a bunch of people with cancer. But we do talk about the etiology, and we used to really talk about it and say, this is your stain on the cancer shows that you got this from HPV. It's a viral induced cancer. It's actually a bit irrelevant, and it freaks people out. But there is a wonderment why they got it when they don't smoke and they live well. But the bottom line is that patient got it from probably exposure when they were 15. The virus is long gone, but it had, produced cellular changes that lead to this evolution of cancer 20 to 30 years later. The partner's not at risk because the HPV disease, like the virus in the mouth, is gone. So they're not really infected. Does vaccination help? Somewhat. And they're not sure about that. But the bottom line is, even though it's common, there's only certain humans with it. But what we're trying to do is prevent, so that if I have a patient with cancer, what ends up happening is his grandchildren go out and get vaccinated, his nieces, nephews, all his friends on his hockey team, whatever, the kids' hockey team or whatever, just because they realize that this is a preventable disease for the most part if you believe in vaccination. But you're right, we do promote vaccine for the people that have it, but we're really trying to prevent the acquirement of HPV disease before we get to the cancer. And you know, every day there's more studies that the work on cervical cancer is just incredible how it's gone down in incidence. And part of the reason we know that, here's one of the difficulties with throat cancer. We don't have a pap smear in the throat. One day you wake up and you got throat cancer. There's no pre-malignant lesion to check. There's no way to test people if they're at risk. They just all one day have it. Whereas in the cervix, it's so easy to study because the pap smear shows pre-malignant cellular changes. And I work a lot with the gynecologists. I've spoken many a time for the Gynecology Oncology Society of Canada, because we're in the same business. One's up here and one's down there, and we're in the same business of prevention. But they have an advantage over us because they've got a pre-malignant marker and the pap smear, which we don't have. So the long answer to the question is we recommend the vaccine, but we're really, if we do believe that the vaccine is going to prevent this cancer, then we're trying to target people before they acquire the disease, before they're sexually active, or while they're sexually active, while they continue to be sexually active. Yes.
I have two questions.
Yes.
My first question is, after going through chemotherapy, radiotherapy, is there a high rate of recurrence of this type of cancer?
So it's really fast growing cancer to some degree. So what happens is, you know, the doubling time of cancers, like all cancers are different. Some cancers can crumble and come back like 10, 20 years down the road. This cancer is funny in that you either make it 2 years or you don't. It grows pretty quick. So if you get that 2-year post-treatment time, I tell my patients to celebrate it because it's probably gone and not back. You cannot say that with other cancers. I'm going to deal with thyroid cancer, good grief, that can come back in 5, 10, 15, 20 years. But head and neck cancer, one of the cool things about it is you are on edge. You wonder if you're going to live or die, but there's only a 2-year worry factor for that for the most part. So that is, you know, the one bad thing about, I mean, it's bad to have a tumor that doubles fast and grows fast, but one good thing is it declares itself. You make it or you don't, 2 years.
That's really interesting.
Yeah.
My second question is, as dental professionals, we're always worried about needle pokes. Is there any risk of transmission through
No.
a needle poke? No.
It's me.
Deep kissing.
You know, in any sexual
Yes.
practice, it was, you know, they don't write about it, but no one likes to, because it's so weird, because it's sexually transmitted. No one wants to talk about it, no one wants to read about it. There's an incredible backlash about vaccination and the whole concept of this, by religious groups. And I mean, that was before our new vaccine controversy, so. Yes.
I have a lot of questions, but I'm going to respect everyone's time.
I'll give you my email.
So as a 39-year-old woman, if
Yeah.
I get it now, it's not going to do anything?
Well, no,
Like
here's
the
one,
vaccines.
yeah, no, oh, no, so yeah, people get the vaccine on page 45. I mean, if you have a single partner and you've been with that partner, you have got it already. So if you're monogamous, your exposure is 0. Other than what you've already been exposed to, the infection is already got, so it doesn't matter. So if you would be unlikely to reacquire the disease if you're monogamous.
So getting the virus or getting the,
If you're monogamous and you're that age, the chance of it benefiting is more.
okay. Second question, if you have your tonsils removed, does that? So that,
Everyone asks that question, what's scary? The answer is no, it'll just go on the base of your tongue. The base of tongue is hidden. It's one of the tricky things is the base of tongue. I mean, you think it's hard to get it down, it's hard for us. We have scopes now, thank gosh. And I just came from afternoon scoping that. In some of these cancers, you'll get a CT scan that says they think there's a tonsil cancer in this neck. The neck, you look at the tongue and you can't even see it. It's really subtle. We play this game where we try not to miss it. We don't mean miss some, but they're hard to see sometimes. They're hard to detect or hard to biopsy. It's a tough cancer to deal with. But yeah, if you have a tonsil, it doesn't really do it. Sorry. Yeah.
I'm sure you talked about how great we are as oral health professionals, how we in your profession. And I'm wondering if why we're not embedded at the cancer clinic to help the patients who experience chemotherapy, radiation therapy, that destroys their flora in their mouth and end up having other oral problems. And if you see that in the future as oral professionals being embedded in cancer, working a lot.
Yeah, so I've been involved, when I came back, I had trained in the state and then too when I came back. When I came back, I was the only head and neck surgeon, and before then, oral surgeons, there was a couple of them floating around and did a bit of stuff. Dr. Flanagan was one of the originals, but, so when I came back, I tried to resurrect the head and neck through global treatment. The cancer clinic were interested, but not interested in the cancer clinic. We didn't have very good investigative tools like radiology and pathology. So I tried to resurrect all that. I created this head and neck tumor rounds. And as you, I don't know if you guys know, but when you have radiation, number one, you have to have all your rotten teeth pulled. You have to have your teeth that aren't looking so good pulled. And then once you have radiation, you have no saliva and your teeth basically fall open on the rubber. I'm being exaggerated, but the bottom line is there's an incredible need for dental care. So get this. We send our patient to the cancer clinic, and we get a letter back saying, sorry, treatment's delayed because we only have one dentist working here and he's super overloaded and he can't get all the patients. And then some of our patients can't afford dental care. There's no follow-up. So it's awful. I'm in the cancer clinic when you, and I'm not picking on them, but when I bug them and say, can you guys not improve your dental alliances, your dental cooperation, your dental team? The answer is, no, we've got other things to worry about. So no one but me knows the value of any type of dental professional for the groundwork of extractions, monitoring, education, oral health. It drives me crazy. I've been on this. I just had a guy in the other day who said, doctor, you told me I had this cancer. I went for treatment. They told me I had all my teeth pulled. Now I need implants and dentures and government won't pay a cent. That's true. Here's some poor soul that has cancer. He gets all this instructed dental work to be forced him to have because he's got this treatment and the government won't pay a cent for it. He's got to pay out of his pocket. So just from government coverage to government supplying personnel, it's pathetic. And the dentistry, you know, when you talk to them at the university, they're overloaded. So yeah, I wish. In Alberta, I mean, I worked a lot with the Alberta Dental Society. I worked with orthodontists, oral surgeons, dentists. They're so proactive. They're getting a fee to administer the vaccine. They're so into HPV prevention. I mean, they're aggressive. They are the pioneers. I mean, even in Saskatchewan, our dentists are better at family physicians. You know, unfortunately, the family physicians, they're better than the family physicians at identifying mouth cancer and all that jazz. So I support the dental people have been awesome in Saskatchewan and Alberta. They're even more aggressive. I've been trying. Yeah.
Just to build on a couple of the questions. So can you explain how the vaccine works? So if I get the vaccine before I'm sexually active, it will prevent me from
acquiring the HPV disease. We can measure that because they're doing tons of studies where we can isolate it in your saliva. I've got in these long PowerPoints. There's some studies that show 100% prevention and eradication of the virus in saliva. It's incredible. But the new vaccine covers 9 subtypes. There's really 2 main subtypes to cause the cancer. I'm not sure if you knew, but HPV has 200 subtypes. Some cause like papillomas or warts. That's what's called papillomavirus. So the vaccine is actually, you know, amongst adolescents is very valuable for preventing genital warts and things like that. So the vaccine has been incredibly effective in all of the studies from benign disease to malignant. Just incredible. Like we're talking numbers like 100%. And second, it's been quite safe. I mean, with the coronavirus, you know, you're hearing all these stories about, you know, the heart thing or whatever. With the HPV vaccine, just the number of usages, because it's all over the world. It is the amount of side effects of the vaccine is super low, it's shocking. It's a really good vaccine. It's 9, and it covers 9 subtypes.
So if I've acquired the virus,
Yeah,
and then I get vaccinated, does it?
it's still a risk, a lower risk.
Okay.
Yeah.
Okay. So it can still, that your dormant virus can still.
Yeah, and it's such a weird thing. How can the virus sit there for, and just like clockwork? I mean, in a week, if I see 5 patients, they might all be 56, 57, 58. It's so bizarre.
So I'm gonna speak upon myself.
Yeah.
I had the vaccine when you had to pay for it,
Yeah.
and the cutoff was 25, so I got it years ago. But, I wish I would have known more about it because I'm not invincible to getting cancer
Yeah.
now. right?
Yeah, I mean, like I said, I'm in the cancer business and, yeah, the vaccine, we really think prevents cancer. I mean, it doesn't just prevent COVID, it prevents cancer. So I wish we had vaccines elsewhere for that. It seems to be incredibly safe. I mean, every vaccine is different. When you make if you ever go into vaccine production, it's an incredible science. And for whatever reason, they fluked it off that there's 9-valent vaccines. It's hard. It is so hard to make a 9-valent vaccine that there's only one out there. And no company, I don't think in this day and age can even afford to make one right now. COVID, at least, you make a vaccine yesterday. But this HPV is tricky and 9-valent altogether that are compatible is really difficult. And you get it, so.
So I have a son that was born in 2006, so he was actually the first year of boys that was eligible for it, and there was lots of hesitation at that point.
Yeah.
And they really only marketed it for prevention of cervical cancer at that point. It wasn't really marketed for prevention of
Yeah.
throat cancer, and I just remember saying to my friends, well, who am I to, I'm going to prevent cervical cancer, my grandchildren's mother, basically is what I said, and they were like, okay, and so when I put it that way, it sort of opened up.
Now we're
my mindset.
preventing men's stroke.
Yeah, we are now, yes, but
Yeah.
back then it really wasn't
Yeah.
even marketed.
And so when I was the president of Canadian Society and I was on this mission to get boys approved, the cost for boys in Saskatchewan was only like $600,000, something minuscule. And the cost of these head neck cancer patients, like you get radiation every day for 6 weeks. Chemo is 3 doses, it makes you deaf a quarter of the time. I mean, the treatment's awful, but the manpower required for cancer, they're overwhelmed right now. I don't know what they're gonna do. They're overwhelmed. They don't have enough chemotherapists. They don't have enough. The radiation oncologists are so overworked. The machines are backed up. It's an issue. So, prevention is always key. I mean, and that's the cool thing about dentists and oral health personnel is that's one of your names is prevention, whereas doctors were a little slow on the prevention thing.
So how many women do you see to men with this?
So it's 4.5 to 1.
Oh.
Yeah.
Just for throat.
For a throat, and they're trying to study why, for whatever reason, men harbor HPV in their throats longer when they catch it when they're adolescents or young adults. And so they're trying to study why men, we've got the same tissue, it's so weird, right? Like in the throat, our tissues are identical. So it has to do with persistence of HPV infection when you're acquired back when you're, 15, 17, 19, 20, whatever. Yeah.
And I work in public health as well. So, when this was first implemented, it was freaking out, oh my God, we're doing this because we want to get this vaccine to girls and boys who are sexually active at age 12. Now we're going to be encouraging them to be sexually active, et cetera. Is there a time?
Oh, believe me, yes, because I got letters from religious groups where, because we have the vaccine, it will promote sexual activity if you're covered. Or the most common is turning down that, there's vaccine hesitancy, there's anti-vaxxers, and with COVID, oh my gosh, that controversy is even bigger. But, a lot of parents think their kids aren't sexually active at that young an age, and, I'm a parent of 3 kids. If you ever read the studies, it's like shocking that you think they know everything or, have a parent, but you don't.
Did the vaccine age actually drop down, or like is it still?
So I think it's the vaccine monograph says, I think age 9 or something like that. But they target grade 6 to 7, they just picked up.
Well, yeah, it goes back to the conversation about, oh my God, I think it is 9.
And again, you do, it may not be the age where statistically there's a peak, or you would have the initiation of sexual activity, but more so they sort of want to be immunized 2 years before to build up immunity before you get exposed. So that's why it's sort of 2 years before the study saying sexual active. And of course, when the HIV epidemic came out, human beings were somewhat conscious of the fact that they could avoid acquiring HIV if they didn't have sexual intercourse. And they thought oral sex was a safer method of sexual activity, and then, so that's part of what happened as well.
What could we be doing to assist, advocate, lobby for the college agenda?
Education. Again, I'm not, I'm a throat surgeon and I do trachs, and so in COVID, nothing, it hit me more than anything, meaning, I was on the front lines, I was doing trachs and COVID. In terms of vaccines, I'm not huge, crazy. I'm a supporter, 100%, but I'm not, an activist about it. But I see everyone's point of view. So yeah, I promote the vaccine just because I believe it works and it's safe. There's other things. Good grief on the surgeon. The side effect rate from surgery is not zero. So everything we deliver is positioned as side effects. But yeah, so education, promoting the vaccine, promoting oral health, early detection. It is the best thing in the world is to prevent, but that ain't gonna be 100%. So early detection is valuable. Little cancers have 100% cure rate, especially in the oral cavity. Big cancers don't. Once a week, I see something from a dentist that's a little cancer that they picked up early, that the family doctor, and one, started getting to see your family doctor. And two, they're not as astute in recognizing pathology. So again, I'm putting my hats off to the dentist, but early detection, if patients are encouraged to go for regular dental checkups, and that's awesome, because they don't go for regular mouth checkups at the family doctor. Family doctors are overwhelmed, it's hard to see them, they're going head to toe, and they just don't look at enough mouths to know it's normal and not normal. So that's where, early detection is so key. And then once, and helping out the cancer patients who have oral cavity issues. I've had dentists refer me neck masses. And now you guys know, if you have a neck mass here and you're in your 40s and 50s, it's not a good thing. Send them immediately to your ENT doctor. I see everyone within 48 hours that has suspicion of cancer, even though I'm busy. There's only so many patients. It's a false alarm to care. I can see the patient in a minute, see it's all good, and off they go. So that's the part I do, is I'll see anyone within 48 hours. I take many referrals from dentists. I know dentists often refer to oral surgeons, and we work in conjunction with oral surgeons. The oral surgeons tend to do the small stuff, we do the big stuff.
Would you take a referral from a dental therapist?
Absolutely. Yeah.
And do you ever does it ever travel past the throat?
Yeah, so we see HPV-induced larynx cancers, but we don't know the significance. The main thing is the oropharynx, and we're wondering about the oral cavity. It'll come out 10 years that the oral cavity is significant too. They just haven't studied that.
But not like esophagus?
No, it ends, it's in the upper air digestive tract for whatever reason. And the tonsil's always been weird. Lymphoid tissue is weird. I don't know if you remember that mad cow disease, Jacob-Creutzfeldt virus. It lives in brain and tonsils. Tonsils are special. They're bad characters. They're invented us. Tonsils are good stuff. That's what they do. Yeah.
I wanted to ask also, I work in the industry and I see a lot of young kids with herpes.
Yeah.
Is this a stepping stone or anything related to what's to come?
Yeah, there's always harbingers of, there's groups of sexually transmitted diseases to some degree, and if they have one, the statistics say they're more likely to have another. Groups are sexually active for the most part. There is herpes simplex 1 that's unrelated, but it is a different virus, of course, it's HSV, not HPV, but it's usually just a marker to be aware, Slides.
Great selection.
So I hope I spelled out what I was talking about with any further questions. Yes,
So in addition to our oral cancer screening,
yeah,
any symptoms that they might be
great question. So the SAR that neck masses have the time, so, you know, I mean, we don't expect you to be, you know, expert on neck exam, but, you know, and by the way, if you get a lymph node, it's in level 2, so like clockwork, the lymph nodes that drain the tonsils are right here, you don't have to feel the whole thing, so, and you could spend 5 seconds feeling here, or you can even ask the patient if he's noticed any bumps there. Bleeding is a sometimes sign pain. The scary thing about this is these patients come in with neck mass, and I know they had tonsil cancer. I know that. And I'll say to them, does surgery, no, any bleeding, no, I looked at it, the cancer, I don't even know it's there. That's odd, and I hate to even mention that because most cancers are painful, most cancers bleed or something like that, but it is subtle. But having said that, half the patients do present with pain. So I'll give an example. So today I was in my clinic and a lady came in, she was, you know, middle-aged and she had pain right there in her throat. Well, I didn't find anything, but that's the type of patient who has HPV-induced tonsil cancer. She's the right age. So what I told her, I don't see it today, man, but you're coming back in 6 weeks when that pain's gone. So I had a student with me and I said, what twigged you about the examination? He said, smoking. I said, yeah, but now that's out the window with HPV. She had one cancer before, she had melanoma, probably not related, but I said the unilateral nature of her symptoms. So whenever patient symptoms are on one side, there's a higher probability of cancer. Because you're not going to get it on, if you don't get it on both sides. It's the way it goes. It's weird, you think you would. You're predisposed to it, but it's always on one side. So unilateral pain is probably the most consistent symptom. Maybe bleeding, you know, difficulty swallowing, a feeling of a mass. I mean, some people, you know, the throat is pretty forgiving. You don't feel, we have people come in where the thing is out there. And we're like, how do you walk around like that? But that's the problem is we see people with tonsils that big that are benign and they don't have these symptoms. I mean, the oropharynx is very forgiving. I mean, you can't have a football in there and not notice, but you can have a golf ball in there and not notice.
You know, most, like, do you know how they're diagnosing? Like, are they using the Bell scope or do you know what Bell scope is or?
That's a great question. So there are sort of, there's a oral surgeon in town who is Dr. Amanda Gruza, and she's got that instrument, the Bell scope, where you can sort of use light and some dye to look at pre-malignant changes. But for the most part, I mean, mucosa is either normal or it's not. In the oral cavity, so you can generally see it without those fancy instruments. The fancy instruments are more so if people have some subtle leukoplakia or lichen planus, and then you can see areas that look worse. But that's one of our problems, but not a problem, but you know, see a lot of people with leukoplakia at the side of the tongue is pre-malignant lichen planus. And we play this game where we constantly examine them. Sometimes they develop a little cancer in part of it. And we work in conjunction with the oral surgeons. You know, we have some patients that float around and, you know, I feel bad for them because they're always developing these little tiny cancers on the side of the tongue. Those aren't HPV. Those are just oral cavity cancers, which you guys are a part of as well. And so, you know, even though I'm talking about HPV cancer, of course, the incidence of lateral tongue cancer from rubbing my teeth, by the way, that's one of the etiologies that we don't spell out, but it's definitely true that our lateral tongue cancers are from rubbing our teeth. It's not in the literature. I've been in business for 30 years. I've seen for every 1,000 cancers I see at the side of the tongue, there's not one on the dorsal of the tongue, and it's the same tissue because the dorsal of the tongue doesn't rub in any teeth. So, and these people just have these mouth postures that, you know, rub their tongues against the teeth. So, but yeah, direct inspections the best. You don't have to have a fancy scope or staining. You're going to pick up on 99%. Those staining methods are mainly for people who already have it and trying to grade it. Be simple, look in. And what's my comment to family doctors? I over biopsy, meaning if I'm worried about something I biopsy, but I don't think it is something. And then I would say over refer. Don't be shy. You're better off to over-refer than under-refer. If we say adds nothing, patients don't care, we don't care. Better to over-refer than under-refer. That's my attitude. I don't know if the World Surgeons feels the same. That's fine.
Any other questions? And it has been a long day, and I know that you specifically asked to come at the end of the day because you're an extremely busy person.
I had 2 basic clinics, you know.
I'm afraid because we were behind all day.
Okay.
But this was actually very informal. I think we actually probably learned a lot, right?
Yeah.
Like a one-on-one with a specialist.
I think all my charts and slides might have bored you, which is mistake, so I'm sorry it's didactic without colorful things. But I just wanted to spell it. It's very confusing what we're talking about, HPV tonsil cancer. I'm not talking about the tongue ones, the lateral tongue externals.
So thank you.
All right.
Thank you.